This conference will now be recorded.
Good evening, everyone. Appreciate everybody taking time out of their day to join us here this evening. I'm sure you heard the announcement here, but the webinar will be recorded for our use and for folks that weren't able to make it. Um, I know that a lot of you are extraordinarily busy right now. We're glad you were able to join us for some important updates. We're very fortunate. We've got two very knowledgeable speakers here this evening who will certainly no doubt provide us with some great perspective on kind of what's happening in the state and what we can expect moving forward. And we're grateful, very grateful for them taking time out of their schedules to share their view with us and eager to hear what they have to say. We'll be first joined by Dr. Randall Williams, Director of the Missouri Department of Health and Senior Services. And then that will be followed up by Dr. Karen Moore, Associate Professor at SLU, an infectious disease expert, NP. All of the microphones are going to be muted. You're going to see on the right side of your screen in the webinar controls, you'll see a drop-down option that says chat. So to ensure that we're able to host a webinar without any distraction, all microphones except for the presenters will be muted. If you have a question, please type your question in the chat feature and we'll ask those as the speakers conclude their remarks. So my name is Derek Leffler, the Executive Director, Chief Executive Officer of AMNP. Again, welcome to everyone that was able to join us. Our first speaker is someone you guys have probably heard quite a bit and seen front and center over the past few weeks in regular updates from the governor as well as from himself. Dr. Williams has been seemingly everywhere, and he's no doubt been very key in our state's efforts to combat the pandemic. He has an extensive resume that's as impressive as it is long. He served in a number of different health leadership roles before becoming the director of the Missouri Department of Health and Senior Services in March of 2017. So it's my pleasure to introduce Dr. Randall Williams to the group. Dr. Williams, thank you so much for taking time out of your schedule to inform Missouri's MPs.
No, thank you very much. We learned a tremendous amount when we talk to clinicians, and the governor and I are incredibly appreciative of what you're doing. You're certainly at the forefront of our efforts to flatten the curve and limit this virus. First patient was diagnosed on January 21st in Washington State, and I was on the phone on January 27th, a Sunday, with my friend John Weisman, who's state health director there, learning as much as I could about that case. We stood up our incident management team the next day, January 27th, and we've been meeting every day for 2 months. So whereas most people are just really kind of focused on this for about 3 or 4 weeks, we've been at it for now more than 2 months. And so our response is very much predicated initially on containment, trying to keep cases from coming in the United States or at least travel acquired. But it has moved into mitigation now as we have community transmission. We really have kind of 5 clusters. We have about 75 counties have not had a case, realizing that we haven't done testing in all those, but we have clusters in St. Louis County, St. Louis City, Columbia, Kansas City, and Springfield, and certainly have community transmission in those communities. We do not have an antiviral. They're working on remdesivir at the University of Nebraska, which was used in the first patient in Washington State under compassionate care and worked. So we're hopeful for that, but it'll be a while. And we don't have a vaccine. It'll be, next March or so before we have that. So it's really back to basic public health, which is education, people understanding they can reduce respiratory illnesses by 16.1% by good hand washing. And then identification, isolation, quarantine of cases. And so that's what we've been doing. We've been doing testing. The testing is more than 95% sensitive. The disease is most infectious at about 5.1 days, which is the median incubation time. We, as a rule, don't screen asymptomatic people because you get a high prevalence of false positives. We are fortunate this is not like H1N1, which I lived through in 2009. It very much affected pregnant women and children and went through the summer. This is the exact opposite. It does not seem to adversely affect pregnant women in great numbers or children, but is incredibly pathological in older adults with an infectious rate that's twice as infectious as the flu and a mortality rate that's 10 times greater than the flu. So about 2 out of 100 people will die, and that's linear. 90-year-olds die more than 80-year-olds, die more than 70-year-olds. About 99% of the cases worldwide who died have been over 50, but tragically we had a 30-year-old die here in St. Louis recently. There have been very few children under 9 who've gotten it, but I think had one in California recently. So right now we're in a strategy of trying to identify those cases. We're doing anywhere from 1,000 to 2,000 tests a day. There are 28 mobile sites. And our 2 number 1 priorities in Missouri right now are personal protective equipment for our healthcare providers like you. If you look at the data from Italy, and I looked at it pretty closely this weekend, sadly, their first responders, nurses, doctors, nurse practitioners have all been very adversely affected. So that we are very concerned about our healthcare providers. And that's why we put out an order for $18 million yesterday for personal protective equipment and an order for $11 million today. And we've put out everything from our strategic national stockpile on Friday and Saturday. So we are pushing it out as quick as we can get it. The EMS, nurse practitioners, nurses, physicians. The other part of our strategy is to do community testing, as I said, through our 28 mobile sites. And then we changed our criteria on Monday for our state lab. We do about 70 tests a day. The positivity rate for both commercial, and I think we have now 8 commercial labs in Missouri, and both the state is about 6 out of 100 will be positive. So you've got to remember right now that for every 100 tests we do, and we only do symptomatic patients, so everybody with a fever and a cough and their chest hurt who thinks they have COVID-19, only about 6 out of 100 do. The other 94 don't, thank goodness. Our criteria changed into 3 groups: nursing home residents. We had an outbreak in Springfield. We have an outbreak tonight going on in St. Charles. So we're incredibly sensitive to that. We know that when this disease gets into confined structures like hospitals and cruise ships and nursing homes and prisons, it tends to become very infectious. So we've restricted visiting hours. We've gone through all our protocols. We've increased our infection quality control. But we know from worldwide experience that that's a challenge. The second group is clinicians. We've really given more discretion. We've moved away from travel-acquired criteria to clinicians. If you're a clinician in a hospital and you need to make decisions, I got a call today from Texas County. They've had somebody down there for 8 days that they've been using personal protective equipment because they're just waiting for their COVID-19 test to come back and been waiting 8 days. And so we very much want to avoid that. And then finally, the last one is first responders. So that if you are a nurse practitioner or a physician and you have been exposed to someone with COVID-19 or somebody suspected of having COVID-19 whose test is pending, you get moved to the front of the line if you have symptoms. So we will get your test back the next day. We don't have a backlog with a state lab. So we very much want our first responders not to be worried any more than they have to and not to be sidelined any more than they have to. So that's a huge priority for us. Our motto is hope for the best, prepare for the worst. If you ask me what the hope for the best is in Missouri, we're doing some preliminary modeling. The CDC has not done official modeling yet, so this is kind of preliminary. But what we hope is that by testing and social distancing from the governor's order, you've got 6 communities under shelter in place that will be able to do like Singapore and flatten the curve and keep sick people away from other people, get into warmer weather. Evidence out of MIT that warmer climates have less disease, similar to the Spanish flu in 1918. That if we can get through flu season, which usually winds down in Missouri by April 15th, get more warm weather, get increased bed capacity with people not having the flu in the hospital, decrease the number of people walking around with fevers and coughs from the flu. If we can get to late April or so, the combination of all those things, we hope, will get us to a better place, that we'll start seeing some daylight. But in the meantime, for the next 2 to 3 weeks, we think we'll continue to see an increase in cases as we do more testing, as there's more community transmission. We will be very much focused on our high-risk groups. We meet almost daily with the Missouri Hospital Association. We have bed capacity, we have ICU capacity, we have ventilatory capacity. But some communities are being challenged. Springfield, at the moment, is a little challenged, but our other communities are good. So I'll stop there and answer any questions. But again, very much appreciate what y'all are doing, and you're very much on our minds, very much on our thoughts, trying to keep you safe.
Hey, Dr. Williams, this is Margaret. And I just typed in the chat box. What about, you talked about confined areas like nursing homes and things like that. What about homeless shelters? I mean, we have a lot of homeless people here in St. Louis that don't have a home to shelter in, and so they're going to shelters, and that's a really vulnerable population packed in pretty tight quarters. Are we doing anything to protect that population to prevent the spread?
Yeah, it's a great question. We talked to Ascension today, and I'm going to start up a mobile clinic, I hope, very shortly, working with the St. Louis City Health Department. One gap in our testing is North St. Louis in a population that would include homeless. So we can pay for their testing. If they're diagnosed, they obviously don't have a home to go to. They don't go to the hospital if they're not sick enough. And we're making provisions where we would house them for the 10 or 14 days that we needed to do with that. But I would tell you that I think that's a gap in our testing. If you look in St. Louis, Kansas City, and Springfield, among an indigent homeless population that is, as you point out, is very vulnerable, that's an area we need to improve on.
Thank you very much. There's a couple other questions here. Hang on just a second. Let me scroll down to them. How backlogged are tests for patients at this point, and what's the current approximate turnaround time?
There's no backlog for the state. We have 1,900 tests. We do about 70 a day. We do it the next day. Nobody waits. For commercial labs, we hear different things from different people. We talk to Quest and LabCorp about every other day. We've got Viracor and Lee Summit. I would say I'm hearing of tests coming back in 2 days out of St. Louis from Mercy. And then I'm hearing of tests coming back 7 days with other commercial labs. So I would say the answer is probably anywhere from 2 to 7 days for our commercial providers.
Okay, thank you. And is there any concern about the availability of the COVID-19 test kits?
We hear that. When I talk to LabCorp and Quest, they say that's not an issue. Kansas City clearly had an issue with that, but they got 1,000 yesterday, I think it is. So that's not an issue right there. I talked to the president of LabCorp, I guess, on Monday, and they're validating new brushes. So they just don't legitimately think that's going to be a big issue going forward. So I hear sporadically that it is. I heard that today from St. Louis. But when we talk to the major testers, they say that will work its way out. Our goal has always been to have really widespread testing by April 1st, and we're on track to do that. I think by April 1st, we'll be in a pretty good position. But again, the best way to decrease the testing is to decrease the number of people who need to be tested. So getting out of flu season and having people stay home is the best way I know, as the Surgeon General told me today. I talked to him on the phone, of addressing people's concerns about first responders getting sick, about the amount of PPE, and about the number of tests. We would be greatly helped if people would follow the governor's order and not associate with people any more than they have to.
Okay, thank you. Another question here. When can we expect proper PPE in the hospitals? Right now, having to use a gown for one patient the entire day, unless soiled. This is shared with all healthcare providers treating the patient. We throw away at the end of the day.
Yeah, I think realistically, it's going to be about 10 days. I mean, we basically went from hospitals supplying their own PPE, and they usually had about a 60-day supply, to literally every coroner, mortician, EMS, fire department, law enforcement, ER, big and small hospital, private providers, and FQHCs, all of them at once not having enough. And that's, if not nationally, globally. So we put aside in the last 2 days $29 million to buy it. We have found vendors, so it's coming, but realistically, I think it'll be 7 to 10 days.
Okay, thank you. Do you have a prediction of the curve flattening in Missouri?
Yeah, I mean, my hope is that if we can get through like the 3rd or 4th week of April, with more testing, more people sheltering in place, following the governor's order, warm weather, flu season going away, people with a cough and fever being much more diagnosable, that I'm hoping by the very beginning of May that we will see more daylight. We'll see daylight. That's if you look at China right now, after 2 months, they've had really no new cases for 9 days. They had more draconian measures than we did, but if you look at Singapore, that's doing a lot of what we're doing. They flattened their curve. So I am hopeful. Now, I'm also aware of these very dire, predictions. Certainly in New York, it's very, very concerning because of their density. Good gosh. It's kind of a pandemic nightmare, the proximity of everybody, all using the same elevators, going up in 50-story buildings, and no sprawl. It's all vertical. So I certainly understand when people look at New York City, for instance, that they're very, very, very concerned. But I think here in Missouri, we don't have that kind of urban density. We've had the luxury of having about 5 weeks to see what was happening in Washington and New York and California. So it's a definitely hope for the best scenario, but that's what I think is going to happen. But on the other hand, I do worry that we will have clusters that we're already seeing of nursing homes and institutions like that, where, King County had 36 people die, I believe, in one institution. And so I remain in the interim very worried about that, our nursing homes and those type of facilities.
That's a good segue into our next question. With concern for nursing homes, would Medicare bed holds be extended for families to choose to take nursing home residents to private residents for protection to lessen exposure to as many people?
Yeah, I mean, I think we would be willing to consider anything. My 90-year-old mother's in a nursing home, and I've just told her, her mortality rate for 90-year-olds is 10%. I mean, mom is 90 years old and never doesn't take any medicines, basically. I mean, she takes 1 or 2, but COVID-19, if she gets it, it'll change all that. It's a very serious disease in older people. So, for your loved ones, and if you're involved with nursing homes, I think anything you can do to minimize, their exposure, group dining, or, certainly visitation, taking temperatures of workers as they come to work every day. I think that's clearly a major area of concern for us.
Thank you for that. Next question, how far are we from a statewide shelter in place order?
Yeah, 15 states have done that, and to some degree. The governor was asked that today, and we're not there yet, but it changes. I mean, as he's always said, all options are on the table. There are issues with that, and the biggest one being if you put it in too early in places where there's absolutely very little disease, people will not tend to treat it with the seriousness that it should be, so that if you need it later, we always compare it to speed limits. If you make the speed limit 35 miles per hour on Highway 70, that can have negative consequences in that people will ignore it. So we have to weigh that in. But we have community spread, at least in 4 communities. So it's something that will remain on the table, and we literally look at it daily. But we think because we have 80 counties that haven't had evidence yet, and certainly no evidence of widespread disease, that at this point we're still kind of watching that closely.
Okay, thank you. Next question, how likely is it that the governor would sign an executive order allowing APRNs to practice with barriers lifted, especially those who have just retired or whose physicians have retired, leaving them without a collaborative practice agreement?
Yeah, I can't answer that. I just don't know the answer to that. I know that has been brought to the governor's staff's attention, and that's where it is. I don't know what the trigger for that would be. And so, but, as the governor said, all options are on the table as far as solutions. And so I would say it's one that's, on the table, but that's all I know about that.
Okay, thank you. Have you seen at this time nursing homes refuse admission of recently hospitalized patients?
Yeah, and that's the problem. I met with the Missouri Hospital Association today. We meet with a group every day. It was the Missouri State Medical Association on Saturday, infectious disease on Sunday, pediatricians last night, nurse practitioners tonight, hospitals today. And yes, we've seen that, and that's really tough on our hospitals because they need to get people out of the hospital. So we're addressing that, trying not to make that happen because the hospitals need the beds for potential patients coming in with COVID-19.
Okay. Any additional questions for Dr. Williams? One quick question here. As far as the process of acquiring that PPE, obviously there's a lot of the folks that work for the big health systems, other folks are taking care of that for them, but what about the small clinics and those in the rural areas? What's the process look like for that?
Yeah, and that's very much on my mind. I had my own practice, and so I wasn't part of a big conglomerate. And clearly, the prioritization for this is hospitals, EMS, long-term care facilities, and that's for the Strategic National Stockpile. For the $19 million we're spending, that's a different bucket of money and doesn't have those conditions on it. So what we need to do is I need your association to put in a request with Sandy Karsten and SEMA as a provider association, and then you would do the distribution. But we don't think it's fair that people who aren't part of a large conglomerate don't get, the PPE. So make sure you do that, and then we would leave the distribution to your organization.
Okay. I will reach out to her and her staff tomorrow. I appreciate the heads up on that.
Well, we've heard that from the pediatricians and the Missouri State Medical Association that, there's no doubt that at least with the Strategic National Stockpile, it goes to the big hospitals and the people employed there. We just don't think that's fair. The other ought to go to people who are in private practice or independent clinics and that kind of thing.
Agree. Looks like there's a question here. What is the state's outlook on the ENT and GI professional organizations putting forth additional? I'm going to have to unmute you here for a second, David. I'm not quite sure. There were some typos in there. Hang on just a second. Let me unmute you and you can ask him directly. Okay, David, you should be unmuted. Are you there? David, you're unmuted if you want to go ahead and ask your question.
Okay, I'm sorry. Can you hear me now?
Yep.
I can hear you, yeah.
Okay, my apologies for thumb typing there. My questions were I had two questions. First, what is the state's outlook on the fact that we are seeing hospitals, my own included, abandoning state testing and going almost solely with private labs because of the restrictiveness of the testing requirements that the state had put forth?
Well, we changed it on Monday for that very reason. So, I mean, they're all designed for your hospital now, which is one of the criteria is for a clinician making decisions on hospitalized patients, it goes to the state lab. So you'll get it back in 24 hours. And the other one is if you have a provider who thinks they were exposed or were exposed, it goes to the state lab and it's back in 24 hours. So
I'm talking about my patients specifically.
Say what?
I am testing my patients in an outpatient environment, not in the hospital. And we are using private lab because the state continues, if we call, doesn't think that they need to be tested. We did that in last week numerous times and moved to use a private lab because the state wouldn't test our patients.
Yeah, well, yeah, it doesn't sound like they meet criteria though. So we save our test for the sickest patients. And if you're testing them as outpatients and they're not healthcare providers and they're not in a long-term care facility, then no, we wouldn't do that test. That needs to go to a commercial lab. Yes, that's correct.
Okay. My second question is the physician professional organizations for the ENT groups regarding the GI professionals that are publishing papers regarding additional symptoms that has been seen, particularly I believe it was 30% of the patients in Wuhan that were presenting with that as their initial symptom, as well as the GI symptoms, which are not a part of.
So that you're saying 30% of people present with GI symptoms?
I think he may have a bad connection. Are you still there?
Sorry,
Dave?
no, I was saying that there was a paper published by the. Yeah, I'm still here now. It is coming in and out. Again, I apologize about my Wi-Fi. No, there was a paper published by the ENT group that indicated that 30% of the patients in Wuhan were showing up with symptoms such as loss of smell as their presenting symptom.
Yes, I've seen that as well. What we're not seeing as a rule, although I've seen figures of 5% of people presenting with true GI symptoms like diarrhea, nausea and vomiting, that kind of thing. That's very much the minimum. The two most presenting symptoms are dry cough, and that's in probably at least more than 75%, and then fever, which is in 85 to 98%. But I'll tell you that that's not universal. That you're also seeing, you know, patients who swear they didn't have a fever. As we go through the forms looking at how people present, we are seeing that. So you have to kind of maintain a high index of suspicion. But as a rule, after 5 days, most people will present with a dry cough or a fever or shortness of breath. You see that a lot, where people just feel like they can't breathe. They get dyspneic after walking. It's a lower tract disease as a rule. It's not upper respiratory. It's not runny nose and rhinitis, and it tends to be truly a lower tract disease, pulmonary.
Okay.
Well, thank
Thank
you.
you.
And I hope you have a good rest of the call. And if we can help you in any way, please let us know.
We appreciate it, Dr. Williams. Thanks so much.
Thank you.
All right. Appreciate Dr. Williams. I know he's an extraordinarily busy person right now, so I appreciate him taking time out of his day to speak to us. Dr. Karen Moore is our next presenter. Dr. Karen Moore is a DNP, APRN, ANP-BC, FAANP, and FAAN. She's an associate professor at SLU. She has an extensive background in infectious diseases. She's a fellow of the American Academy of Nursing, a member of the expert panel on emerging infectious disease, global health fellow of the American Association of Nurse Practitioners, International Council of Nurses, Nurse Practitioner Advanced Practice Nursing Network Subgroup Chair, Chair of the Global Health Special Interest Group of the National Organization of Nurse Practitioner Faculty. She's also a member of AMNP, and we're very grateful to her for sharing her expertise with our members here tonight. I'm sure you're going to be impressed with her depth of knowledge. And Dr. Moore, we appreciate you taking time to help educate our members. Give me just a second here, and I'll make you the presenter and unmute your microphone here. All right, you should have full controls now, Karen. You'll just need to share your screen there.
Can you guys hear me now?
Yep, we can hear you, but you'll need to share your screen up on top there in your webinar controls. There you go, got it.
Okay, can you guys see the PowerPoint now?
Yep.
Does that look okay?
Yep.
Okay. Thanks so much for having me. I'm so glad to be following Dr. Williams. He has taken so much time talking to various groups and trying to get the word out there, and really is doing a great job with trying to mobilize PPE and testing for us. And that's obviously going to be very important as we face this crisis. So I wanted to kind of go through the background and things that would be helpful for us to know. So first of all, I have no conflicts of interest to report. This is a lovely picture from the CDC of our friend, Mr. COVID-19. He's not our friend. COVID is known as the coronavirus. Corona means crown. So all the coronavirus family typically causes upper respiratory infections. It can also have symptomatic GI piece to it. They are positive single-stranded RNA viruses in alpha, delta, beta, and gamma varieties. Past strains that caused really serious issues were MERS-CoV in 2012, that's a beta. SARS-CoV, which was in 02 and 03, that's also a beta. And now the novel coronavirus SARS-CoV-2, also known as COVID-19, which is a beta chain as well. The interesting thing is that these viruses tend to come from animal reservoirs to humans, commonly bats, pangolins, cats, camels, and pigs. MERS-CoV, they believe, is from a camel. They haven't fully determined that, but they believe it's camel-driven. Also, we see coronaviruses as avian flus that are typical. The R0 is an important definition for us to understand from an epidemiologic standpoint. And I bring that up because we're seeing lots of data coming at us, and as NPs, sometimes it's hard to take it all in. The R0 is the basic reproduction number. So it signifies how many people can contract the disease by a single infected carrier. So the R0 of COVID-19 is about 2.2 to 2.5. When we compare that with seasonal flu, that's usually 1 to 1.3. So you can see, we know how flu season is and how easy it is to catch the flu. You can see that for COVID, it's twice as likely to be caught, but it's exponential. So that's an important thing. COVID has these big spikes, and the corona spikes attach to the ACE2 receptors. The reason that's important is because when you look at some of the research that's ongoing and some of the recommendations that were originally brought out and now are kind of no to listen to that, was based on ACE inhibitors and ARBs. So, and that's why. Just kind of a little timeline I thought would be helpful, because I know if you guys are like me, you feel like you've been kind of like in Caddyshack, where you're living the same day over and over again. It's a long time, but it's really a very short time because it's so constantly evolving. So in late 2019, the disease first appeared in Wuhan, which we all are very well aware of. But if you look at the actual dates of things, they reported the cluster first to the WHO in December 31st. January 7th, they had already identified that it was a novel coronavirus. January 11th, the first death was reported. So that's a pretty short period of time. The first case was already outside of China by January 13th. And if you really look at that, that's under 2 weeks. They put Wuhan and Hubei under quarantine, which was their attempt at isolation. And we have the first case in the US, the first death in January 20th. So that's pretty quick. That's pretty quick spread. The WHO declared a public health emergency towards the end of January, and the president banned travel from China at the end of January. The first death outside of China was in the Philippines, February 2nd. An American died in China, February 8th. February 9th, which again, if you remember, this really just started towards the end of the year. Now we're only 2 months in the beginning of February, and the death toll had already surpassed the first SARS outbreak. So that tells you that it was moving with a rapidity and a virulence that was not previously seen in other coronavirus outbreaks. The cases began to spike in South Korea in February. And the reason this is important is because you'll see later, South Korea did a lot of things really right. And that's kind of who we have been looking to emulate. When we look at Iran's outbreak was right after it, Italy's outbreak was right after that. So the 21st, Italy's outbreak began. At this point, where we're sitting today, South Korea is basically on the other side of the curve. They flattened it there. It's very under control there at this point, it looks like. And Italy, we know, is sadly not under control. And part of the reason is for those decisions they made early in the outbreak, that their public health departments made early in the outbreak and their citizens made the big difference. Italy was placed on a lockdown March 8th, WHO declared a pandemic. The US declared a national emergency, and New York City is on March 23rd confirmed 21,000 cases. So that's clearly for the US. We thought that it was going to be Washington State because that's where we saw that first pocket in the extended care facility and the nursing home facility of deaths and infection. And California has had issues, but clearly New York City, like Dr. Williams was saying, they're just set up for an epidemiologic infectious nightmare because of how they're sitting. So I have a couple statistics on these slides that I think may be helpful in just kind of showing the difference in the various countries. So globally, the World Health Organization, and this link is at the end of the slides, the World Health Organization updates these daily. So if you look at China right now, we're looking at, oh, hold on, I lost it. We're looking at 81,000 total infections, new infections of 146, new deaths of 7. So when we kind of look at their total infections and then their new infections, that gives us a clue as to where they're at with controlling the spread. South Korea, 9,000 total infections, 76 new infections, deaths are going down. So clearly they're on the other side of that. Italy, unfortunately, 63,000 infections with 4,700 new infections, 6,000 deaths. So they are still, and new deaths of 600. They're clearly still escalating. They're still in the steep spike of the curve. Spain is the next one on queue and is really struggling. Madrid is having a terrible time right now with COVID, 33,000 infections and 4,500 new infections. So if we look at this, if we look at the Germany and France and how they're going up exponentially as well, and then we come down to the US with 42,000 cases and 10,000 new infections. Largely those are being seen in New York City with some smattering across the US. if we drill down into the US cases, according to the US statistics, the US looks at it, the CDC looks at deaths slightly differently than the World Health Organization. So that's why you'll see some diversity in the numbers. So the World Health Organization breaks out Puerto Rico and Guam differently because they're geographically different. So the US CDC puts them into our counts. I did this chart for you guys because I wanted to look at the cases, Washington, California, New York, obviously, but then I wanted to look at the ones that are touching us. So Illinois is having an issue that's pretty substantial at this point, and they are still escalating. Texas, Kansas, and Arkansas, not as much. Iowa, not as much. So those are things to keep in mind because, you know, people who live close to Kansas City, Kansas is very important. People who live next to St. Louis, Illinois is very important because there's so much transit that occurs across those borders. So it's important to understand what communities that are nearby touch us. This information is from the Missouri Department of Health and Senior Services website. They also update it daily, and the link is there at the bottom. So that's nice if you're trying to stay up to date. And that's what I would tell you the most important thing is, as nurse practitioners, is for us to stay constantly up to date. Epocrates also has a very nice little link in there for clinical trials and medications, and as new things happen, they're updating it. So everything is happening very quickly. It's important that you know where to get current good information. The age distribution in Missouri, there have been 8 cases under the age of 20. And if you look at it, the age distribution does tend to go up. And we do have 60 between 20 and 29, so fairly young people as well. And those are based on testing. So how is COVID-19 spread? This is sometimes a little bantered about how it's actually spread. It's primarily spread through droplet nuclei, respiratory droplets from coughing and sneezing. Social distancing is important because if you're at least 6 feet away, the thought is you have to have a pretty big sneeze to sneeze more than 6 foot. Not that I haven't known people who can, but if we keep distance, then it's much easier to avoid that droplet spray. Can be aerosolized in some situations, for example, very forceful coughing, especially if you're a healthcare provider in a room with the patient, during respiratory different procedures, and during intubation. It can be on contact. The surfaces that get contaminated with respiratory droplets then can be transferred to the eyes, nose, and mouth. We are seeing there's some diversity in opinion on how long things last in the air and on various surfaces. The thought is that in the air, it could be suspended if it's aerosolized for up to 3 hours. On surface, they were originally saying up to 9 days. Now with looking at the cruise ship, they have identified it up to 17 days after. So certainly cleaning, regular routine cleaning is very important of surfaces, and being careful about what you're coming in contact with. Rarely it can be spread through fecal oral routes. And the reason is that we have seen coronavirus, the ACE binding site is in the lungs as well as the gut, which is why some coronaviruses like SARS, for example, had a GI component that was quite large as one of its presenting symptoms. We haven't seen as much of that with this particular variety, but it is still a symptom. So you kind of want to have a very high level of suspicion for anyone who presents, especially in an area of spread. So all persons are at risk, but some groups are at higher risk for severe disease. Anyone over the age of 65, living in long-term care facilities, those with lung disease, cardiovascular disease, immunocompromised, and interestingly, people with severe obesity, as well as underlying diabetes, renal disease, and liver disease. The reason this is important is because when they prioritize testing, like he was saying that, like Dr. Williams was saying, they prioritize testing from the state lab, but they've also expanded who can be tested, which I think was a question that Derek had, is that they have, this is from the state's website. So they are prioritizing testing for hospitalized patients, nursing home, living facilities with high-risk individuals, patients who have contact with them, and consider factors such as a high number of local community cases. You can also consider those comorbid conditions to determine when you're going to test, as opposed to when you would have them go home and hang out and do that sort of thing. And obviously, as more testing comes online, the goal is that you would increase your numbers of tests, because when we increase the number of tests, we actually do identify, and then we can isolate and we can help to prevent spread. But currently, the reason that the testing was being so stratified is because it is risk stratification relative to the number of tests available. So as more tests come online and as more availability loosens up, we're going to be able to get a better idea. I included the list of Missouri testing sites. Again, that's on the website. As that changes, that's something that's going to change frequently. It is recommended to call the site before sending patients because you want to determine what is their eligibility and availability for testing at those particular sites. There's nothing more frustrating than sending a patient and then finding out that they don't meet their criteria. They meet your criteria, but not their criteria. And patients will require an order for testing. There are new tests being approved routinely. So there are rapid assays, a couple different ones that are 30 and 45 minutes. So they're going to be rolling those out in hospital-based settings first, obviously for the sickest patients, but also for healthcare providers, because they're very concerned about identifying healthcare providers who are at risk and then could be at risk of spreading. In Italy, like he was saying, that has been a really sad component, is that they have been working so much with inadequate PPE often that it has resulted in healthcare provider exposure. There is also a finger stick test that is in development to test for IgG and IgM antibodies, and that will help us know full prevalence of the disease. There is also one that Bill Gates, the Gates Foundation, in conjunction with Google, is rolling out for and Amazon with home testing for sample collection, which will help to decrease the amount of exposure for healthcare providers. And that would be done not on a nasopharyngeal, but more just a nasal swab, because, you know, patients would find it very difficult to do their own nasopharyngeal sampling. So prevention, we know that social distancing is very important. Missouri order was enacted March 23rd. It's in effect until April 6th. That may be extended depending upon what's happening in the public health sector. No gatherings of more than 10 people. These are all things that we can reinforce to our patients. Only drive-throughs, pickup, and local delivery, restaurant and bar food. I know this is a review for most of us. We're probably just deluged with it, but I felt it important to include it. No visitors in ECS nursing homes or assisted living. Maintain a 6 feet minimum distance, and work from home is preferred. So for prevention, washing with soap and water is preferred, and at least 20 seconds. Wash frequently. You can never really wash your hands too much, I don't think, until we get all chapped in the winter and then have to use all of our lotions. But special attention to hand washing after toileting, before food prep, after eating, and after coughing and blowing nose. If soap and water is not available, you may use a 60% alcohol-based sanitizer, but that is not preferred. Of course, avoid touching your eyes, nose, mouth, or face. Cover your sneeze or cough. Clean all high-touch surfaces at least daily. And this would count for your home as well as for your offices and your equipment. So your door handles, your countertops, your bathrooms. A bleach solution is preferred according to the CDC website, which is about 5 tablespoons per gallon of water. An EPA household disinfectant that specifically lists that it can kill viruses is okay as well, and a 70% alcohol solution. Remember to pay attention to contact time on the packaging, because just kind of doing a one swipe wipe, which is often what I see done in a lot of healthcare institutions, is not going to be sufficient. You need to consider it doing a terminal clean of every spot that you're cleaning for this particular virus. Signs and symptoms usually occur in 2 to 14 days. 5.1, like you said, is the mean time that we're seeing. So about 5 to 6 days, most people will present after they've been exposed. Common signs are the fever and the dry hacking cough, shortness of breath, and malaise. But the loss of smell and taste has been noted by the Society of Otolaryngology. And some will report that they also have sore throat, myalgias, and nasal congestion. Like I said before, the diarrhea may be a presenting symptom, and we may see different things as we go along. In some studies, it's been noted that people who present with COVID-19 and have diarrhea often have a worse course of the disease. So again, but data is still ongoing, so we really don't know entirely what it will be. But if you see any of those things and you have reason to suspect that your patient could have been exposed, then certainly move towards testing. Mild disease is characterized by a fever and the dry cough and some minor symptoms. The action should be to triage them over the phone, instruct on self-isolation. If you have telehealth, this is a great time to use it or to consider using it. you want to consider the immune status of the patient as well as the household contacts, because you want to think about, are they at risk of worsening quickly? COVID-19 can start out very mild and within a few days be very bad. So it's not your typical course where oftentimes with other upper respiratory infections, you'll see them kind of going down, down, down for a period of time. With COVID, they may look really okay and doing okay for a little bit, and then all of a sudden they're hypoxic or confused or are having other issues and need to be rushed to the ED and intubated. So you always want to think about that risk stratification as we're going through, because those are the patients you want to be most concerned about, even though we're seeing it in younger patients as well. In these patients, you may be able to manage them at home. And our goal is, if they do have very mild disease, it would be nice to keep them out of the hospital, just because we all know if you go to the hospital, sometimes you get sicker. So there's that goal. For moderate disease, we again see all those symptoms of mild disease with the addition of shortness of breath and sometimes cyanosis. So this is where they're really getting a pneumonia-like presentation. That's what you're seeing. They're presenting with a COVID pneumonia. You can triage them over the phone. If you believe that they need ER evaluation, then certainly do that. EMS transport. It's important when we're looking at an infectious disease, normally you would say, go to the emergency room. In this case, you want to find out where they're going and call ahead and try to notify them you have a potential COVID patient coming. If you're calling from your office, you're obviously going to tell EMS it's a potential COVID patient coming, so that they would be taking adequate precautions. For those of us who are in COVID areas, like St. Louis City, St. Louis County, Kansas City, and Springfield and Boone County, that would be kind of assumed somewhat, but in other outlying places, you certainly would want to do that. In children, sometimes you will see tachypnea without other signs and symptoms. Kids, they sometimes run along fine until they aren't. So this is a disease much like that. Severe disease is characterized by marked dyspnea, lots of respiratory distress. They look pretty bad. They're hypoxic, usually below 90% on room air, and they are obviously an EMS transport. These folks are the ones who are at very high risk of early intubation. So in hospitalized patients, commonly they will progress to ARDS and sepsis, and then they will be treated for those issues, much like they would be under standard protocol. But what they noticed is in China and Italy, they seem to say that patients, it looked like they were improving with non-invasive ventilation support, and then suddenly they precipitated downhill and needed mechanical ventilation pretty quickly. The big thing that they brought out of that was, and a lot of the reports that I'm reading, because it's all evolving so quickly, is some are clinical reports, clinician reports. And what they found was clinically that patients looked like they were improving, and the normal thing would be, oh, they just needed a couple of days rest and now they're improving, so let's start the wean. And what they found is that these guys quickly bounced back and decompensated. So they're currently basing that, they think that you will need mechanical support for these patients once intubated for about 1 to 2 weeks. The clinicians also recommended that if you're looking at maintaining them on mechanical ventilation, that you really look at the PF value, as opposed to that you look at saturimetry as opposed to the straight PF values, because typically in ARDS you would just be looking at the PF value, and these guys, that's kind of misleading. So that's just a clinical pearl for anybody who works in acute care settings. Patient teaching for COVID-19, which many forms can be found on the CDC's website as well as on the Missouri website, should be regular prevention measures if suspected or confirmed. So self-isolation for 14 days, which should include a separate room with the door closed if possible, separate bathroom facilities, disposable utensils and plates and things like that would be preferred. And if you cannot do that, then certainly have separate ones for their use. And the person handling them should wear gloves and load them in the dishwasher and run it on high. Strict hygiene measures for the patient and for the caregiver, with frequent hand washing, separating towels and washcloths, frequent cleaning of hard surfaces. So not just daily, but probably several times during the day. The patient should wear a mask if leaving the room, and the caregiver should mask if going into the room, and no visitors. When to discontinue isolation? Now, this has been a topic of conversation amongst a number of people, a number of groups I've been in. But the current recommendation is that they wait at least 7 days after symptoms first appeared and 3 days after symptoms resolve. So that means no fever, and that can't be because they were on ibuprofen or Tylenol. No signs of respiratory illness, so no cough, no shortness of breath, and no signs of illness at all. So they need to be fully resolved for at least 3 days, and it has to be at least 7 days after their symptoms appeared. So we would prefer in healthcare workers and in hospitalized patients to use the 2 negative COVID-19 tests administered at least 24 hours apart. But in the absence of testing, then they will be using this other protocol. But I would expect that we'll be using the 2 negative tests coming up soon, at least in Missouri. It looks like we're going to have adequate supply for that. If a healthcare worker, they will need to wear a mask for a full 14 days after symptoms, even if symptoms resolve sooner in their return to duty, because again, we don't want them to be exposing other folks. And we know that, I believe it was Laura had a question on the last with Dr. Williams that didn't really get answered, but about the shedding of virus by children for 21 days. We've seen shedding of virus in stool for up to like 30 days. So, so that's something that we need to keep in the back of our head when we're thinking about people who may be exposed going back into their life and doing food preparation tasks and those kind of things. That could be important. Occupational considerations, I have it broken down into kind of what you're doing for your clinic and your staff and all that sort of thing. So in your clinic, you want to make sure that you're instituting an aggressive phone triage telehealth. You don't really want people just walking in with disease, and you want to train your front desk person to really screen for it effectively. You want to rearrange your waiting area and your patient schedule to allow for social distancing. So you don't want everybody coming in at 9 a.m. If you can do older folks in the morning, younger people later on, that's fine. Make sure that you're spacing out those chairs so that they are appropriately separated. And institute aggressive frequent cleaning of door handles, seating in exam rooms, and consider leaving the main door to your office open just to prevent the constant touching of the door handles. Consider delaying any routine follow-ups or using telehealth for routine follow-ups like medication refills and people who are stable on their current med regimen. When you're looking at patient screening, you want to consider having a questionnaire and an immediate temperature measurement for all patients entering. So if someone's coming in and they're, saying they're fine, but they have an appointment scheduled with you, you may want to have a questionnaire that says, recent travel, contacts with COVID patients, signs or symptoms of COVID, and then just take a quick temperature as soon as they arrive. That way you'll be able to more quickly screen out patients that could be at risk for you and not have them sitting in your waiting room for 30 minutes coughing or shedding virus when they're asymptomatic. You want to limit moving your patients around the clinic and cluster care for each patient in one area. So that way you're not traipsing and exposing the entire clinic during the time period when they're there. If you don't already, you might want to consider routine patient screening for depression, intermittent partner violence, and abuse. With the shelter-in-place orders and people being inside their homes, it's anticipated that depression, seasonal depression, and abuse and violence could be escalating. So that's something to consider. You want to think about the occupations of your patients so you can consider potential exposures for them and for yourself. So are they commercial drivers? Do they drive Uber, Lyft? Are they healthcare workers? Are they working in food service? How might these things impact the decisions you make for them when it comes to public health? A respiratory room designated and a mask for all patients who feel ill upon entry in the clinic are also important. And you want to limit sending patients for non-urgent testing. So CTs, MRs, and X-rays, because those are potential areas of exposure for your patient. And the recommendation is that we not do those kinds of tests right now, if possible. So for your staff, all of us as healthcare providers are probably feeling a little anxious in our own heart and in our own life. And certainly our staff is feeling that anxiety too and that stress. A lot of things have changed, a lot of processes have changed, and so these issues can be very problematic. So when you think about some of the testing and some of the procedures you do within your clinic, it would be important to stop routine tests and procedures that have the potential for aerosolization. The American College of Occupational Environmental Medicine recommended that routine pulmonary function tests are stopped for typical in-process health exams. Breath alcohol testing is another thing that you may want to consider suspending for a period of time. If you're doing it for suspicion or cause or non-routine, then you need to wear full PPE with an N95. Nebulizer treatments should require a full PPE. Suctioning would use full PPE. So anything that's going to aerosolize the secretions would require a full PPE. It would be a good time to review a donning and doffing of PPE with your staff, because they don't necessarily have to do it as much if you're an inside and an outside clinic. Provide direction and contact information to EAP or counseling programs if needed by your staff. Consider daily screening of staff with a questionnaire and a temperature. A lot of people are doing that, where they basically have a quick little sheet that says, have you been ill? Do you have a cough, shortness of breath, da, 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 da. And then they come in, they do a quick temp, and you move on. And when you're thinking about staffing, you got to be ready for quarantines and exposures, because if your clinic gets exposed, or if a particular one of the providers in your clinic gets exposed, that could be a significant issue for the ongoing care of your patients and yourself. When you think about clinical decision making, you want to think, if a patient's calling in for an appointment or for any kind of symptoms, you need to think about, could this be COVID? And the suspicion has got to be pretty high. Do they need emergency transfer? Do they need testing? Do they need treatment? What am I going to do for all those things? So this decision tree will hopefully help you kind of think through what you need to do. And it might be a good teaching tool with your healthcare staff, your front desk staff, to help them really walk through the phone calls that they might receive. It's difficult often for non-licensed personnel to really have a full grasp of what is the nuance of what to ask and how to tease out that information. So having a script is really important. And I believe the CDC has a screening script on their website that you can look up as well. PPE is definitely an issue, and I was glad to hear Dr. Williams talk about that today, because that's, as healthcare providers, that's something that we really have considered. I'm happy that he is going to be utilizing AMNP to help with some of that for our outside clinics. Things that you might want to do, though, to conserve it within your clinic is to think about limiting the aerosolizing procedures, limit the number of employees engaged in activities requiring full PPE, identify which ones would require N95 versus full PPE with splash and goggles, and consider suspension of most invasive routine procedures unless it's truly medically necessary. The FDA and the CDC recommendations, again, like Dr. Williams said, prioritize use of gowns and surgical masks by types of patient activities. Most of those would be done inpatient and in hospitals. Face masks should be given to patients who are ill to prevent exposure to others via coughing and sneezing. Treatments. So this is the kind of interesting part. All treatments that we're going to talk about are under investigation. They haven't been approved for use in COVID-19 patients to date, because the studies are still ongoing. Prophylaxis and outpatient treatment with any of the medications listed is not currently recommended. Drug shortages have already started cropping up on things like hydroxychloroquine and chloroquine. And some state boards of pharmacy, Texas was leading out on that one, are moving to make outpatient prescribing of those medications, and that includes azithromycin, restricted, because they're seeing drug shortages already. So you would have to be able to put down why the patient is getting that, what the diagnosis was, and if they're already on something like Plaquenil for long-term, which is hydroxychloroquine, then those patients would be allowed to continue. But for other patients, they're very suspicious of that. Currently, there are 86 clinical drug trials going on. And like I said before, Epocrates has that nice little drug trial update. The American College of Cardiology and the American Heart Association put out a statement that they do not believe that discontinuing ACE inhibitors or ARBs is a good plan. And if the patient is controlled on them, you should plan to keep your patient on them. At one point, I don't remember, several days ago, there was kind of a big push of maybe we need to take people off of these. And they came out and said, no, that's really not the issue. But again, that goes back to thinking about, we're learning so much about this. Where is the binding site of COVID? Steroids are generally avoided related to their negative impact on ARDS and the rapidity with which these patients can progress to ARDS. So while you normally may think, oh, I'm going to give, a steroid pack or a Medrol pack or whatever, you might want to think about that in the meantime. So if you're treating them if you're sending them out to be tested, you may not want to put them on a steroid, because that may in fact worsen the condition. So some treatments that are being explored, some antivirals, remdesivir, he spoke about, it's an Ebola med. It's by Gilead. It was originally for compassionate use, but now they've suspended compassionate use related to the demand for the drug and related to, they have ongoing clinical trials now to try to prove efficacy. A couple antivirals have been used in Japan on a Japanese study on 340 patients in Wuhan, which they said they got good results from. But again, they're all happening in real time, so not not a randomized control trial. Kaletra is an HIV med, and that is also being studied because we know that this virus acts much like all the other viruses, which is it's single-stranded, it's an RNA, it goes in, it attaches, and then it unravels itself and implants itself within the host cell. And without that unraveling, anything they can do to block any of those places is what's going to block the replication of COVID. Antimalarials such as chloroquine phosphate and hydrochloroquine sulfate are FDA approved for malarial and autoimmune conditions, and they are frequently used for things like lupus and various other autoimmune conditions. A 2005 study on SARS, chloroquine did interfere with replication, so that's why they are excited about exploring that here and thinking that it might have some merit. There are studies in China, France, South Korea, and the US. The French study has been kind of panned a little bit relative to, it's a very low N. So that's why Dr. Fauci is not like a huge fan of saying, let's just all go in and do it, because we certainly hope that there will be a promising drug that would beat back at least the most severe cases and perhaps be a prophylaxis that we could use. University of Minnesota is looking at that for prophylaxis of close contacts and healthcare workers specifically. Of note, it's important to note and to make sure your patients know that the chemical used for cleaning aquariums, known as chloroquine phosphate, is not the same. So don't use it as a medication. We've had one death related to that. Someone did that, I believe, was in Arizona. Other treatments that we're looking at is immunosuppressants. Because what happens in these patients is they get towards the end where they get that sudden rapid decline is because what's called a cytokine storm occurs. So the cytokine storm occurs, they have this huge inflammatory response, and it just overwhelms the lungs. And some drugs that we're looking at for that are Actemra and Kevzara, which are both IL-6 inhibitors. Losartan, interestingly enough, which originally people had said, oh, take them off it, is now people are interested in seeing if it can prevent hospitalizations or prevent multi-organ failure. So keep posted on that one. Vaccines, there are a number of trials going on, as you can imagine. And the convalescent plasma infusion was most recently brought up. It's a 100-year-old procedure where you take blood from recovered patients and you inject it back into patients to aid in speed and recovery. It was used in the Spanish flu epidemic of 1918 and Ebola. Some treatment concerns that we need to consider are with the quinines, so the chloroquine and the hydrochloroquine. Some efficacy was seen in samples of seriously ill patients, like we talked about, China, France, and even at UCSF, it is part of their treatment protocol for inpatients, serious inpatients, is that they use both hydroxychloroquine, chloroquine, and azithromycin as part of their protocol. But at that point, they're looking at very seriously ill patients who really, they're going to throw everything at them that they can. So there's not a lot of data that's come out yet, but they have that built in the protocol. They're pretty old drugs, but they aren't without side effect. So we need to make sure, like with chloroquine, that people are screened for G6PD. It can cause psychosis. It can cause retinal damage and blindness. The bigger things are it can cause prolongation of the QT as well as azithromycin can. So if you're using those together, you have to really think about dysrhythmia and what is the underlying conditions of the patient. If you notice, renal, liver disease, and cardiovascular disease are all cautions for both of those, and the patients at most risk usually have renal, liver disease, or cardiovascular disease. So that's something that you really want to pay attention to. It's just like everything else, it's risk-benefit ratio. So for outpatients who are walking around and about 80% will get it and clear it on their own, that's probably not someone that you want to slam with a medication that could do real damage. For patients who are hospitalized and on a vent and very seriously ill, then certainly the benefit outweighs the risk, or the potential benefit. So In closing, I wanted to talk a little bit about lessons learned. We talked a little bit about Italy and kind of where they're at and how they sort of started a little bit late, and their society is very communal and very friendly and very warm, and they like to be out and they like to be walking and socializing. In Korea, there was a patient called Patient 31, and I don't know if you've ever heard of Patient 31, but if you look it up, it's quite interesting. Patient 31 was told, they thought she had symptoms of COVID. She was told to isolate, and instead she went about her daily life. She went to church a couple times, she ate at a buffet, she was just kind of generally interacting. And ultimately, she was found to be the contact for 1,160 people and has been linked to more than 7,800 cases and 60 deaths from COVID. One person. And so when you think about that, we know that social isolation works. It's helpful. And South Korea really turned the tide with aggressive testing, trace identification, isolation, and ongoing surveillance, which are the key components of any epidemiology and public health programs. So testing, they have multiple drive-through and walk-up centers. Once a case is identified, the public health system traces the contacts and isolation of all contacts until resolution is confirmed. They have ongoing surveillance, which I don't know we'll go over real big here, but they have like their big buildings, whether it's office buildings, apartment complexes, they have thermal imaging that they're using to monitor for potential fever as people walk in and out of the building. When people come into restaurants, some restaurants are randomly taking their temperature to make sure that no one has COVID and is coming in the door. If you travel to Korea right now, you're required to download a phone app to be screened for symptoms by all visitors. So they're very aggressively looking at that. And I think that's a lesson learned that we can, especially as nurse practitioners, we can turn the tide by really working on teaching our patients about it, explaining to them why social distancing is important, explaining to our legislators why social distancing is important, and why doing some of these very basic public health behaviors are going to make all the difference in the world for the people in Missouri and the communities we serve. So in closing, the next steps are really just take care of yourself, take care of your staff, take care of your patients, keep it social distance, reinforce hygiene, and keep on top of the news and recommendations as they change frequently. Some important links. Do you guys have any questions?
So it looks like first question was, how many false negatives are you all seeing with swabs?
Well, I think it's a question. A false negative versus just a negative, I think is really kind of the question. If you look at the number that he has tested, there are, I believe it's about 70% are coming out negative, 70 to 80%. I'd have to look back at the stats, but that doesn't mean that they're false negative. It just means that they really don't have COVID. Because I think the sensitivity and specificity is at about 95%. So the big concern is obviously that if we test so many people who are asymptomatic, is that going to give us a false picture at this point in the outbreak? Is that going to give us a false picture? And because of the limited number of tests, we've got to get the people who are symptomatic tested first. So I don't know if that answers their question. I don't know whose question that was.
That was a question from Amanda, I believe. So Amanda, if that didn't answer your question, feel free to submit
I see.
a second.
Okay. We have had patients that tested negative swabs and positive with CT scans. Is it related to swabbing too soon? CT scans really are just going to show you if they have pneumonia and if they have characteristics of pneumonia, like a ground glass appearance or consolidation. But if you're looking at actual negatives on the swabs, some of the swab negatives could be that they're not being done correctly. I mean, I don't know about you guys, but the amount of time that I've done a nasopharyngeal swab in my practice is probably pretty low. I mean, that's not something we do that much, right? So I think that some of it could be that we're not swabbing deeply enough, and that could be a problem if they truly do have this, which is why the testing sites are so important, because we want to make sure that we're sending them where we're going to get a good sample and we're going to get a good test.
Another question there says, do you think that Missouri has less cases than Illinois because of less testing?
No, I don't think so. I mean, I don't think that's probably the issue. I think the issue is probably when you look at Chicago, because that's where most of their positives are clustered. They have a situation somewhat similar to New York in that people tend to live closer together. They have, you know, a big center where you may live in an apartment type setting, and I think you just have a more dense population. And so when you have increased population density, any infectious disease is going to spread more easily and more readily. And I think because Missouri has a lot of rural communities, that's why we're seeing the clusters in the urban centers of Missouri. If you think about it, St. Louis City, St. Louis County, Kansas City, Boone County near Columbia, and Springfield, those are our major population centers. But our population centers aren't nearly as big as Chicago. So I think that when we look at that, certainly as we do more tests, I would expect our numbers to go up. I mean, as we increase the number of tests, that's just a foregone conclusion. But I think they could have some things going against them relative to population density that's not in their favor.
Okay, thank you. Next question here, has there been an ask for NPs to cover other areas to support other providers on quarantine or positive?
I have not heard that yet. However, from larger systems, I think that would be almost more of an inpatient question. And I think it depends on how we get overwhelmed. If the system can manage, if we can flatten the curve, like we all want to say, if we can flatten that curve and keep it down to where the health systems can manage the patients that are coming in, then we shouldn't see that. If we get to a condition like Italy or like New York City or something like that, then we are looking at a whole different thing. But I'm hoping and praying that we don't get there. And I think if we all do our part, we won't.
I do know we did have a member up in the Kansas City area that said they got an email from their health system that said, hey, we need to know if you're willing to expand your support to other facilities. Are you willing to deploy to other facilities? Are you willing to help in areas not specific to your practice area? So as this continues to escalate, if it does escalate, I suspect that you'll probably see some more of those sorts of questions. Good question.
Yes, and I think that's being done. Some of those surveys are being done just so that they know so the systems know what to do and how they can deploy staff. I know the health system I work in, they have sent out a message similarly saying, would you consider, because there are several hospitals within the system, would you consider, going here or there and not just in your particular unit? But I think that's just it's just a planning decision at this point.
Question, what is your, hang on a second, there's another one came in, bumped me down there. What is your opinion on having contacts of COVID patients continuing to work with PPE while awaiting results?
Well, I guess right now the recommendation would be no, that if they're, that we need to presume them positive and tell them to isolate. So that's at this point, if we think they have COVID, they need to go home and they need to be isolated. And that's for 14 days. And hopefully if it's that we can get that back sooner. And that's what he was saying, depending upon what field they're in, if they are healthcare workers, then we could certainly get that result back quicker. But yeah, I think that goes for all patients. If they're being tested, they really should not be working. They should not be out in public. They should be isolated at home for 14 days.
Okay. Question about kind of testing. If patients, so there was a limited number of tests in the Buchanan County area up near St. Joseph. It says, the question is, if patients do go to Kansas City for the testing, will the test results be posted as positive, negative tests for Kansas City, or do the testing centers report the results to the county of the health department the patient is from?
I believe that they report it to the county that the health department is from, because they want to know where the patient lives. So where is the, so they can track sources.
Okay.
So that's typically how it's done with all health reporting. But I know this is sort of an unusual situation, isn't it?
Right. Lots of questions about whether or not the PowerPoint will be available. Karen, if you're willing to share this and
Oh, that's
with
fine.
us, then we can certainly send it out to our members and those that took this course, this webinar.
Oh, sure. Happy to do it.
Okay, great. Keep in mind when you get this, obviously the situation is very fluid and is changing with regularity. So, what may be spot on today may change tomorrow. So just keep that in mind if, once we send the PowerPoint out.
I'll add a date to it so that way we have
Perfect.
some clarity on that.
Thank you so much. Any additional questions for Dr. Moore? One question here. We have been told to limit testing until more robust testing available, told relative shortage of RPP collection swabs. Anyone else having this experience? Any role for RPP?
I think that has been an issue in the past. And I know he spoke about that on another call I was on with him, Dr. Williams. And that was a piece of the testing shortage as well, was not just the tests, but the actual collection swabs. So I believe that that has all been ramped up, and we should be able to get those. Now, getting them and testing from within your clinic, probably not. But because I think, again, most of that is being shunted through the state health department. But I think that could be something we could talk to him about as well. But I think that's certainly an issue, and that's an issue they're aware of. So that should be coming online a little bit better here pretty soon.
Okay. Question, do you think any NPs are seeing fewer routine patients?
I think that's probably true. It's true in my clinic, and they certainly are really discouraging patients from coming in if they're healthy and it's just routine. So I think some of those, how do you say it, routine bread and butter kind of visits are certainly diminished. The people who are coming in, from what I'm seeing in my practice, the people who are coming in are sick and need to be seen.
Okay. Question here, New York healthcare workers testing positive with no symptoms are being asked to continue to work. Is this true?
I do not know that for sure because I, obviously am not hooked in with their system. But it would not surprise me relative to when you have that kind of a volume that they're facing right now, they would probably tell them to mask.
Okay. All right. I think we'll stop the questions there. I do have a few closing comments here. Karen, we really, really appreciate you taking time to provide this information. I know this is a very timely topic and very useful to the folks that were able to attend. So we are very indebted to you for taking time out to put the presentation together and speak to it. And we just want to say thanks as close.
Oh, you're welcome. It was my pleasure.
So just want to kind of give you guys an idea of what AM&P has done since all this stuff kind of broke free. First thing that we did was we sent a letter to Dr. Williams on March 14th. We basically requested a suspension of laws and regulations that inhibited NPs from providing care. We CC'd that letter to the governor's office. That was on March the 14th. Also on March the 14th, AM&P issued a joint press release with the Missouri Nurses Association, basically outlining the requests that we made to Governor Parson and Dr. Williams. That release primarily focused on access issues. We have been engaged with legislators. Obviously, AM&P is an advocacy organization, and we're heavily involved in legislative efforts, but that all changed with the development of this. The legislature is essentially shut down at this point. Although we have had several conversations with legislators about what's going on and have worked with them. Some of them have sent their own requests in to the governor's office to encourage the governor to lift restrictions. Some of them viewed it maybe as kind of not the right time, possibly too opportunistic. So when they support the governor lifting those restrictions, but didn't want to go out on a limb there and write the letter. On Thursday, March 18th, we sent a second letter to Governor Parson with very specific requests with reference to statutory and administrative rules, specifically on geographic proximity requirements, the on-site collaboration with the physician providing the CPA, and eliminating the restrictions on the use of telehealth to the rural areas of need. We have been engaged with the Board of Nursing. AMNP and Mona had a joint call with the Board of Nursing and communicate with their leadership on a regular basis. We're trying to understand if an executive order gets issued, what that's going to look like as far as the implementation, and then kind of get some clarity surrounding the federal waivers and some of the additional questions that have been posed by our members. But anyway, we're communicating with them on a regular basis, and as soon as we have confirmation from them on items, we'll certainly send that out to you guys. On March 20th, we sent an update to our members that kind of aggregated all the information that we had collected up to that point. We outlined kind of what steps that we had taken, what resources were available, and then kind of updated folks on AMNP activities for the foreseeable future. As most of you know, we do a variety of different networking events as well as educational things, and we suspended those activities for the immediate future, and we'll not sure when we'll resume those, but obviously we want to take care of our folks and make sure that we're doing our part to flatten the curve. Obviously today we have the joint webinar or the webinar with Dr. Moore and Dr. Williams. And so we hope that this was of value to you guys. It sounds like there was great interest and great questions from you folks, and people appreciated that. So we did issue a joint press release, a second joint press release. We did that with Mona and the Missouri Association of Nurse Anesthetists, basically that encouraged the governor to issue a stay-at-home order, requested additional PPE to all areas of Missouri, and then again calls on the suspension of regulations for telehealth. I believe that we may see some action in the next day or so. It's too soon to make any sort of an announcement on that, but I'm hopeful that we see some sort of action taken by the executive branch here in the next day or two. So we continue to have conversations with the executive branch officials. That includes the governor's office as well as various different administrative agencies. We're going to continue to press for a suspension on barriers, and we'll certainly keep you apprised of anything that is approved. And so with that, I'd ask for questions specific to your association and what AMNP may be doing, or ideas that you may have. Doesn't look like we have any. So thank you again to Dr. Moore as well as Dr. Williams for taking the time to share your expertise. Hopefully everybody found this informative. We appreciate you guys being a member of AMNP, and if we can be of service to you, please don't hesitate to let us know. We will we'll get the presentation out to folks as well as the recording up for those of you that may want to share that with some of your colleagues and that didn't have an opportunity maybe to participate this evening. So stay safe, healthy. Hope to see you guys at a future AMNP event, and appreciate you again taking time out of your day. Thanks so much.